things. So just be an interesting conversation.
Okay,
Is
cool.
that so?
Well, sweet. Um, I want to get right to it then and dive into the details of it. Um, I guess because this is something I'd like to learn myself. Actually, it'll make for natural questions and natural conversation.
Yeah.
So I guess right off the bat, the way I like to process things in my mind is get like solid definitions down and baseline understanding and make sure I know what I'm grasping. So when we're talking about opathies, tendinopathy, and things like that, what are we talking about? And is it how do we differentiate between tendinopathy and tendinitis? Is one specific and one's just a shotgun blast generality, or what are we talking there when people bring that terminology up?
No, I think that's a good question. So to give you a little bit of history on that, that's one of the things that they've gotten away from probably in the last 3 or 4 years, where you've started to hear the term tendinopathy used rather than tendinitis, because
Mm-hmm.
there's a lot of times where people are having pain in the tendon and having issues with it, but there's no true inflammation or no true inflammatory process with that. So they basically shifted away and went and said, let's give it a more umbrella term because to describe all tendon pathologies. Because when we say, well, that's tendinitis, rotator cuff tendinitis. Well, not always. And then we go as healthcare professionals and we try and do anti-inflammatory modalities or treatments or whatever to address the tendinitis, when a lot of times there's not that inflammation present. So then they go in and they say, hey, well, ultrasound for this isn't indicated and ultrasound for tendinitis isn't indicated. Well, there was no true, irritate, or not necessarily irritation, but inflammation there in the first place, or that may not be the only thing going on. So tendinopathy is kind of, yes, the general umbrella term, right? But it can be used to describe whether it's a tendinitis, tendinosis, tenosynovitis, peritendinitis. I mean, it kind of is the umbrella term because it could really be any of those. And now there's certain conditions where you can differentiate a couple of those things, but I think sometimes we found that it doesn't necessarily matter. So rather than sticking with, well, it's inflammatory all the time, or it's stuck in this inflammatory state, we need to call it tendinitis. They've gotten away from that and gone with the more umbrella term. Yeah.
Gotcha. Now, so what do you mean by it doesn't matter? Like the way in which you treat it, the outcome isn't going to matter. So thus, you say it doesn't matter, or kind of describe
Well, I
that a
say,
little
and
bit.
I guess that's a kind of general statement to throw out there for. It's more. I would say that it's not that it doesn't matter in this. Like each individual tendon, depending on where you're at, how much vascularity it has, how much innervation it has, is all going to dictate that and dictate the treatment. So, like in Achilles tendinopathy, right? They do really well with heavy loads,
Mm-hmm.
eccentric, concentric loading. That's the way that tendon is made, and based on its typical disease process, when you think of Achilles tendinopathy, that's what it responds really well to. Whereas another tendon with maybe a little bit less vascularity around it may not respond quite as well to just being loaded like that. Like maybe the supraspinatus tendon, may not respond quite as well to being loaded in that way. So I think it really just depends. So, which isn't a great answer, but I think depends is kind of.
Sure. So what are you talking about between different vascularities, and why does the vascularity difference dictate load or not?
Well, and that's where I don't know that there's a direct correlation between vascularity and should we load it or not. I think it's more or less like not all tendons are the same. Some tendons are created with, let me see, I can even look at it because I even had something over here. So the main things that are in tendons, right, are type 1 collagen fibers.
Mm-hmm.
So we've got over here well-hydrated, non-collagenous ECM, and then that's just the extracellular matrix with glycosaminoglycogens, good gracious, and then just cells. But depending on what happens afterwards. So it's even talking about you'll get like some neovascularization. So depending on how vascularized it is, sometimes they've suspected even in the Achilles tendon that there could be neovascularization or new vascularization there, which is causing the pain. But I mean, when you look at it, so on this synopsis, it's basically it doesn't have as much about like, well, if it's blood flow or not, but it just says it's kind of one of those things that contributes to it,
Mm-hmm.
right? So depending on where it is with any tissue, like if we look at cartilage, it's not very well vascularized, and
Mm-hmm.
so for it to have its inflammation response and to heal, you may see the healing times longer. So I don't know that it necessarily dictates load or unload per se, as much as it just is a contributing factor to maybe prognosis or management of that particular tissue, if that makes sense. It's a roundabout answer, but that's the thing with tendinopathies, man, is that I think we're learning every day. So something I said at the beginning of the call is I've got an article right here to my left where not all tendons are created equal,
Mm-hmm.
implications for different treatments approaches. And one of the things that they bring up later, and this is Lori Meichner, so the lady who she is the vice president for our orthopedic section. She's a really big researcher, especially when it comes to the shoulder. And she is faculty over at University of Southern California. So the prehab guys,
Yeah.
this is the person, one of the people that they learned from. And she's brilliant. But some of the things that they brought up in their article, as far as Achilles tendon management, is old news now, and we would say, maybe that there's more contradictory evidence. So it's changing so quickly. So to say that any one thing works for Achilles is pretty well researched. You should, and we'll talk about this in a second. We have some clinical practice guidelines in our profession that help dictate how we should manage Achilles tendinopathy diagnosis, differential diagnosis, and loading and unloading. But it's
Gotcha.
interesting because in this article over here to my left, it's saying maybe do one thing, and it still says something similar in the other, but there are some small changes. So it's constantly changing, man. And by the time we have this conversation and we look back a year, there'll probably be something new, to be honest with
Gotcha.
you.
So to bring it to some practical application, being like outside of a clinic and away from any sort of modalities or imagery or whatever technology that would be helpful in diagnosing tendinopathy more specifically. Say you're just in the gym setting with somebody, and you see that there's tendinopathy going on in the elbow or knee or something like that. How would you um, specifically diagnose it, if at all? And then what would be your plan of action moving forward in terms of dictating whether they should be loading it or moving away from load? Just sticking there. I know we could shotgun blast 1,000 answers.
Yeah.
So to keep it specific, can you determine specifics to the tendinopathy? And then second specific question, what would be your um, criteria to continue to load it or to cease loading it?
Well, so to answer the first question of diagnostics or like being able to diagnose it, I think we've gotten really bad, and this is not strength coaches or physical therapists. I think health profession in general saying, "Well, point to your pain. Oh, it's right here. Okay, well then that's quadriceps
Mm,
tendonitis, or that's patellar tendinopathy, or that's Achilles," and I think we've gotten really bad at that. And,
mm,
and what happens is I think because there's so much and there's an abundance of information out there, people point to right below the kneecap and they're like, oh, that's actually just going to be basically your patellar ligament. That's an issue. So basically you're having inflammation there, or it used to be the patellar tendon is what they called it. And
mm.
so, and they say, well, that's just patellar tendinopathy. Let's just load it or unload it or do some things there. And I think that's just oversimplification of the diagnostic procedure. I think, can you get it on location sometimes? Yeah, absolutely. I mean, absolutely. But I think you also have to understand, okay, well, how would this behave? Active range of motion. Do you take them through passive range of motion? Do you have them move without loading it at all, right? And then looking at even just general palpation. So palpation, active range of motion, contractile unit testing, passive range of motion, all those things wouldn't necessarily be used in the clinic or be used off-site by a strength conditioning coach because it's the diagnostic piece isn't there. Could you go wrong with guessing sometimes? So, hey, yeah, man, this pain right on the back of my heel. I mean, 8 times out of 10, is it Achilles tendinopathy? If it sounds like a dog, barks like a dog, whatever analogy you want to use there, then yeah, it may be a dog, but it may not be.
Mm-hmm.
So then it goes to your second question of how do you know to load it or unload it, or what am I supposed to do? What I would say is it kind of goes back to load management in general. If the load's painful and they're going up, let's say they're at a 2 out of 10 pain, and the load that they're typically able to use is bringing them up to a 5 or 6, well, maybe you keep them below that. And so to answer the question, is there a way that you guys can kind of manage that? And you see this all around the internet for sure, and we use this with certain populations, is the whole use of the 0 through 10 scale. Mm-hmm. and not going above 2 points on that scale. So any load, volume, exercise that increases that load above 2 points, then you've done too much load. But it also, I think that's oversimplification to some degree too, because you have to, it goes back to that diagram that we were talking about. Then you have to understand that some of these tissues are going to maybe inflame later depending on blood flow. They may do it in 30 minutes. They may do it, if it's a disc, it may be that night or the next morning. So for diagnostics, I would say, can you go wrong sometimes, or can you go right sometimes with going off of where it is? Potentially. I think the knee and the ankle are pretty simple to do it there. Not simple, but I think you probably, the guess is at what the issue is, maybe a little bit more accurate. And there's obviously nothing to say like that, right? But in my opinion, the knee is a little bit more straightforward. Does it mean that there aren't things aside from that it could be? No. But as a strength coach, if you see somebody with infrapatellar pain and you start loading them like we were just talking about, then 9 times out of 10, they're probably going to be okay. It potentially was that secondary to loading too quickly. Absolutely. Mm-hmm. Or something that they did. Maybe they went and hiked 20 miles and then thought they could do the same exact workout that they would normally do, not understanding the potential implications on the tissues.
So it sounds like a lot of essentially experimentation to see what's potentially aggravating, what's not, and then a lot of kind of patience, prod it back off and see what happens. Or
without a guided examination, I think that's difficult, right? I mean, yeah. I think that it's basically using your anatomy and saying like, look, like, it's infrapatellar. I think this may be it. If it is truly, patellar tendinopathy, or now it's ligaments or whatever, but if it's patellar tendinopathy and you load it, like you unload it and then start reloading it again and it's fine, great. But I think just without a proper orthopedic examination, could you be right? Absolutely. I mean, no question. Could you be wrong? Absolutely. And could you irritate that patient further? Potentially. It depends on the case, but I think the shoulder is a whole lot more complicated, and that's where you can't just unload and load. It's the same in the hip. In my opinion, and that's where I think those two are a little bit more complicated. To me, they're more mobile joints, comparatively speaking, right? The hips and the shoulders, I mean, they're both ball and socket joints. They're relatively mobile joints, and I think they can be a little bit more complicated. So my advice to strength and conditioning coaches or anybody out in the gym would be, if it's a shoulder or hip issue, don't even try and guess. Just refer out in that case. If it's knee or anything else, potentially you could, and again, that's oversimplification. I mean, honestly, is it guesswork? No, I think you just have to be really smart about it, right? So you look at everyone's load management and you say, and you have them write down everything. And if I say, man, I was doing, let's say squats, right? I was doing squats. I did a 4x5 at 235 and my knee was just really bothering me. All the other lifts were fine. Well, you're at least tracking it, so you can at least make a better and more educated decision. When we've talked about this before, if you're not tracking those things, then you really shouldn't even be trying to load manage in that individual. Not necessarily not trying to load manage, but if you haven't been doing it, don't try and start doing it when they're in pain. I mean, don't
Right.
try and now start trying to track things. You should have been doing that before so we can get an idea of what's going on. Now I need to manage them and then get them back to the individual.
Now,
Um,
two more bits to that is if there is, let's again to keep it specific, just so we don't shotgun blast the answers. If there is, let's say, knee tendinopathy going on, and rather than, or not rather than, I suppose it's part of it. Instead of solely focusing on loading adjustments, what if we changed to a variation of the exercise? Let's say the squat is bothering it, we do a different style squat, and the pain goes away. Is that enough justification to keep training, or is there still a
yeah,
potential
I
issue
mean,
there? Or
I think a smart coach would absolutely do that. I mean, I think if I come in, I'm like, man, dude, my knee's really bothering me today. It's like, oh, okay, well, as far as load management goes, we haven't really done anything crazy. Did you do anything else? No, not necessarily. It's just bothering me today. Okay, well, look, instead of doing something more deep, knee dominant, we're going to put a little bit more torque on the hips and we're going to do maybe a deadlift or do something that's more hip dominant. Yeah, you absolutely should. I mean, or if they're doing
that wouldn't be potential to exact to aggravate the issue more.
what I would say is when you look at the percentages of torque or load across the knee and the hip with those two different movements, if they're doing them right and not squatting their deadlifts, then I think what you've done is you've shifted the load onto a different joint. And I think if you see like, okay, well, they're able to do it, they can maybe manage or do the lower extremities with deadlifts today rather than a squat, and then see if it kind of goes away. But if they keep doing squats at the same load, then yeah, changing up the lift is perfectly fine. I honestly, man, I would rather have them moving, because I think what creates a problem is when we tell them, well, you just need to rest and don't do anything. A
Gotcha.
smart coach should know how to vary. Well, you know what? Man, if we do a front squat, it's going to be this much pressure on the knees. Or man, if I have them do sprints and do this, they may be putting a little bit more pressure on the knees. Maybe if they go out and do the sprints but do a different kind of squat that puts less emphasis on the knees, fine, right? I mean, and that goes a little bit more into your territory where it's like you're going to know that better than I will, and that's okay. I'm
So,
okay.
so pain would be appropriate to dictate changes. We could go off of that. Hey, this movement is less painful, thus it's okay to go with
Yeah,
for
to some degree, yeah. But then also too, if you decrease the load and you say they're at a 3 out of 10, and you stay 3 to 4, and you're not really changing it from baseline much. The reason why it's 2 points and no one, everybody's like, oh, 2 points means tissue injury. No, it's just minimal detectable change on a 0 through 10. So
Gotcha.
for the patient to see, oh man, this is noticeably worse or noticeably better, it's 2 points. So that's why they say greater than two.
Hmm.
So when you have something or some intervention that basically the patient has perceived is more painful than baseline, that's when they start telling you it's at a 5 or at a 6, excuse me, rather than a 3. And then that
Gotcha.
should dictate you coming back down. Anything in that range, a 3 to 4 to 2 to 5, honestly, what we've seen is that there's no super significant difference in their mind. They already have trouble understanding it, but that's how I would use it. Back off on
Gotcha.
the load a little bit and see from there. But the 2 is no magic number. It's just a minimal detectable change for a patient, basically, to give you that self-reported outcome.
Got it.
I Go ahead.
Yeah. So, and then the second part to that question is, I see a lot with this pain scale. They also associate this 24-hour rule. What is this? Can you elaborate on this 24-hour rule and where it come from,
I
what
think
its purpose is, and
it
is it useful?
depends. Yeah, yeah. So I think, again, as we were alluding to earlier, it depends on the tissue type that's being implicated. If we're talking let's say tendon, and just in general, it depends. But a lot of times, let's just say males our age, rotator cuff tendinopathy may show up that night. It may show up during the exercises, but because of the vascularity of the tissue being a little bit less so than some of the other tissues, you may not get an issue in the tendon until later that night. And you're like, man, I can't sleep. I can't lay on this shoulder. My shoulder hurts me at night. And that's one of the things that we look for diagnostically as physical therapists, is the behavior of that. So tendons may respond later. And then you've got disc that in that same diagram where they look at like 24 hours or so, disc may respond either that night, it may even wake them up, or it could be the next morning they feel stiffness. So the whole thing is basically this umbrella to say if they're 24 hours later not having any stiffness or any pain 24 hours later, then just keep going. I think that's an oversimplification, because 24 hours, maybe the next morning if they don't have stiffness, do I use that for a disc? Yes, I use it for a disc. I don't use it for tendons. If they say, well, I had a lot of irritability that night, but the next morning it wasn't stiff and I felt okay. It's like, oh, well, 24 hours in, you were okay. No, they had pain that night. That's how that tissue responds. I think it's just an oversimplification. I think when you look at the general rule, is it okay? It's got its faults, it's got its pros. I think it's encouraging movement, but I think when it comes to the 24-hour rule, oh, if it's gone in 24 hours, I mean, most pain that I treat in the clinic doesn't last for 24 hours. If it lasts for an hour to me after, regardless of tissue, that's too much. That's too much irritability. That's an acute tissue injury. I say that 24-hour rule doesn't matter, because maybe it is down in 24 hours, but it doesn't mean that it's okay to keep going with the same load. It depends on the tissues, and that would be a fun conversation to have, because nerve responds one way, ligament, muscles, tendons respond differently than maybe a disc, just based on a lot of different factors. But that would be a fun conversation. But we could get lost in a rabbit hole on that. But yeah, I'm not crazy about that. I think if you're suspecting tendinopathy, though, if we're just speaking strictly to tendinopathies, if they're not having any pain with activity, any increase above 2 points on that scale, and if they don't have pain following the workout or that night, then I think you're okay to move forward in a tendon issue.
Gotcha.
If we're just keeping it at that, that's kind of my rule. If you're suspecting disc, we're getting into a whole different ball game. But tendon is that.
And then the ultimate question here when it comes to the opathies, the tendinopathies, what's the ultimate process for this to go away? Is it just simply mitigating aggravation and allowing the body to heal and time take its place, or is there specific things that you need to do to facilitate appropriate healing? Or
so to some degree that's part of it, right? It's unload, educate the patient on, hey, here's what's going on, here's what we need to do, and reload, protect the tissue, unload, reload, and do it in an appropriate manner. Now, it depends on the tissue type. So Achilles tendinopathy responds really well to that method. So they call it, it's basically the EduRep. So education, unload, reload, and it's as unloading, controlled, reload, implementation of prevention strategies, right? And that's basically load management. I mean, that's essentially what it is. So I think in certain tissues, the Achilles tendinopathy responds really well to that method. I mean, really well. And that doesn't take, for the diagnostic piece, sure, I can do the diagnostic piece, but the number one thing that you can do with somebody with Achilles tendinopathy, better than the dry needling, at least based on the research right now, better than, and again, we don't have a ton of high quality evidence in these areas like taping, dry needling, even orthoses, heel lifts. Some people say put a heel lift in there to offload it. That's what they said back in 2014, 2015. Now in the updated articles are saying, it's contradictory. We can't really recommend it. But the thing that has stayed consistent is exercise and loading, unloading, and reloading. I mean, that's in that particular tendon. Now, what I would say is this. It depends on the cause of the tendinopathy. So in the Achilles tendon, I think a lot of times we're talking overuse, maybe some gastric soleus deficits where it's being overused, whatever. Maybe it's biomechanical, something going on at the ankle. A lot of times, though, without doing joint mobilizations and without doing all these other things, you unload it and reload it, you're okay. But I'll give you an example. So I have this guy coming to see me and his shoulder clunks and pops, and he's having some, like, basically I'm suspecting rotator cuff tendinopathy, particularly supraspinatus, based on testing in the orthopedic exam. So if you look at the research, then the research would say, well, supraspinatus, there's no evidence to say if it should be eccentric or concentric, but you should load it. But in his case, the cause is actually dictating I need to do something completely different. So the reason why he's actually having a tendon issue is because he had a labral tear in the past that's caused anterior basically instability, because it was keeping him from, it was basically seating the head of the humerus. It's going forward. The ligaments up front or in the anterior portion have become a little bit more loose per se, just due to it being a little bit closer with movement. And the tissues in the back have gotten really tight. And so as a result, the joint, when it operates, is not operating centrally around how it's supposed to. It's shifted a little bit forward because of that instability. The body goes with the path of least resistance. And so then when you start to load it, concentrically, eccentrically, doesn't matter, you're building on an unstable foundation. When in fact, maybe this person needs manual therapy, some soft tissue work on the back, and then recentration exercises, and then go into concentrics and eccentrics. So it really depends on the cause, on what you choose to do. But when you look at the evidence for most, you could say unloading and then reloading in an appropriate manner does very well. It just depends on the cause, to be honest with you. And that's where, are all physical therapists equipped to do that? No, I think we as a profession do a poor job. I think we chase the pain and we say, well, I'm going to address your shoulder. I had a golfer who came in to see me, and he was having pain in basically his lead shoulder. He's right-handed, so when he turned to go into his backswing, pain with reaching on his left shoulder. And so it was actually a really fun, not experiment, but it was a fun thing, because he was like, well, I'm going to this other physical therapist at a place in town, and I'm coming to you. And the physical therapist was like, wow, why is he looking at your hips? Why is he looking at your thoracic spine? I was like, well, because he's golfing and he has to overextend his shoulder because he can't rotate to his right for his backswing. And basically what we found, I didn't even treat his shoulder. I just treated his hip and thoracic spine, because that's what was causing the overuse injury. And that's where and that physical therapist is like, why is he looking there? I'm just treating your shoulder. I'm just doing traditional whatever, right? I'm doing some soft tissue and loading and reloading. I think it just takes a skilled set of eyes to just basically say, here's what I think is going on, and then manage it from there. If it's truly just a tendinopathy with no other contributing factors, sometimes it can be that way. Then yeah, unload, reload, educate, and then prevent future injuries. I think that's perfectly fine. So
Gotcha. Well, cool. Yeah. I was definitely curious about that umbrella term of apathy and where it's supposed to go, and kind of the underlying issues to address it. But essentially, it sounds like it depends is going to be the answer a lot of times.
Well, and I think that's where it takes someone with the ability to do some diagnostics, someone you trust, and someone that has time to manage these patients. Unfortunately, we've been put in this crappy situation, and we've put ourselves here as a profession to where we're seeing multiple people at the same time. And instead of figuring out, I call it the onion, right? So the onion is it's an onion, right? And the outer layer is maybe what they're presenting with. But all we do is we treat the outer layer. We never want to go deeper and figure out what it is. So that same patient comes to me and they say, I've had physical therapy in the past for my shoulder. I've had it twice. Then I had surgery. Then I had this. And then you go and you're like, holy crap, man, it may have been something completely different. And at that point, you don't know. But I get patients all the time that all they've been treated for is just the pain that they're having at the moment, rather than trying to figure out, well, what is actually causing the symptoms, rather than just trying to put a Band-Aid on it. So I think it does depend, and that's unfortunate, because I hope I wish that we were a little bit more clear on it. Unfortunately, that's medicine at this point, but I think they're doing a good job at least. So we're coming up and putting more funds into developing the clinical practice guidelines, which I think are underutilized in our in basically our profession. I told some people in the clinic that I work in, hey man, use the clinical practice guidelines. They're like, oh, I know they're there. And I'm like, okay, I don't think you understand how many research articles they go through, score them, and then figure out the best available evidence and do all the work for you. The fact that you haven't even looked at them is frustrating. And I think that's where we need to start, is as a profession, if we want to be the people that you're sending someone to for diagnostics, then we sure as hell better do our homework. And we
Yeah.
better know what we're supposed to do rather than just being any, how are we any different than than anybody if someone points to the pain? Oh, it's right here. Oh, that's bicep tendinopathy. Like, that is the laziest, from a physical therapy standpoint. It's just a lazy diagnosis when someone just points and you guess what it is. You
Sure.
have to go through everything. And I think that until we change the way that we approach learning in physical therapy, until we stop trying to just put a bunch of tools in our toolbox and actually figure out what the hell to do with our tools, I think we're learning how to manipulate, and we're learning how to dry needle, which I'm all for, but knowing when to use them, we've gotten
Mm.
bad about. And I think the clinical practice guidelines are where we start. But again, everybody has their own opinion on that, so we'll see.
Gotcha. So you as a physical therapist, when they come in and they present with localized issue, no matter who it is or what it is, would it be safe to say that it kind of like your way of taking their vitals is just getting a quick snapshot of how they're moving as a whole? Do you still look at everything just to kind of clear the slate, or
It depends. So if they're a golfer,
it depends?
if they're a golfer and they say that I have shoulder pain when I go into my backswing, then absolutely. If they say, oh, I just have pain with reaching overhead into a cabinet, then I look at, okay, well, what helps you reach overhead? Well, we need to look at and clear thoracic spine, ribs. We need to look at scapula. We need to look at shoulder. Those are the big four right off the bat. And even cervical spine needs to be screened out before I just make this diagnosis. And that's where, getting and developing clinical reasoning helps. Because if you come in and you say, man, my shoulder's hurting right here, and I jump straight to trying to rule in and rule out a bicep tendinopathy or just a rotator cuff tendinopathy, I'm going to miss the big picture. I'm basically trying to treat a tree without understanding the forest. And I think that's a dangerous mindset. But unfortunately, that's where many of us are, until we develop that clinical reasoning. And sometimes we don't know that that's what we're doing. We think we're helping a lot of times, but I think we kind of fool ourselves into thinking that we're doing a great job when if you have somebody, when this is what residency showed me. I was like, man, I'm doing such a great job. And I was like, crap, that means I did terrible. And then I'd have somebody review my case and they're like, well, did you think about this, and this, to try and eliminate these biases that we go towards. And it's finding, and as a strength coach, Aaron, what I would say is, so you're up in North Carolina right now, but how do you choose physical therapists for that? I mean, one way that we've tried to make it a little bit easier is by getting people who are orthopedic certified specialists, OCS. So they have to take the examination. It's a board recognized specialization. That's one way, is you can look for someone who's an OCS, but it doesn't necessarily eliminate years of experience. And so I think it's frustrating, because when you guys, let's say tendinopathies in general, when you send someone over, then all of a sudden they're doing freaking, and sometimes it's appropriate, but they're doing the most basic of basic exercises, and they've been in there with you going up in weight and deadlifts and squats, and I mean, they feel good about themselves, and now all of a sudden they go to a physical therapist who doesn't fully understand where they're coming from, and they're getting these really basic exercises and basically treated like a piece of glass that's going to break and that's fragile at any point in time. And I think that should make strength coaches hesitant to send people to us and try and find things on the internet to try and diagnose it themselves or try and manage it themselves. And that's exactly what's happened. So I love that we have these conversations, because I think we both get to learn from each other. I've certainly learned a lot from you, and I hope you've learned something from me.
Definitely.
But
Definitely.
it's frustrating, because we've slacked, and we're the movement specialist. And maybe if we get Josh on here one day, he'll probably, if we say that out loud, he'll probably lose it and just go off, because I think we both agree that we as a profession know so little. And once we get our doctorate, we just, we're good. I'll take a continuing ed class here and there to keep up with my license. But I think we, at that point, are like, I did 10 years or 9 years or 8 years of school, I'm good. And I think it's just it's plaguing the profession,
Sure.
unfortunately, and people are turning to coaches, which is great in some cases and bad in some cases as well. It depends on who it is. So
So give me if there's one thing that somebody takes away from all this, if they didn't hear anything else, what's something that I, as a strength coach, need to um, have as a constant when it comes to a tendinopathy? What do I need to have as my um, foundation and to stay in my lane and to also like what is your one piece of advice that is consistent across the board for tendinopathy for strength coaches if in fact they come across these issues that have so much what ifs to them.
sure, I would say first thing is don't try and diagnose it to the patient, right? Don't try and tell, well, I think you have this. Like, no, that's way outside of the scope. So
Hmm.
saying, you've got basically, man, when they basically bring their arm out in external rotation, like that's irritating. Like you can kind of make some guesses to the best of your knowledge and best of ability in that certain case. So don't try and diagnose. B, most tendons will respond well to education, unloading, reloading in an appropriate manner, and then preventing those further injuries by basically strengthening up and load management. A lot of times they will get better with load management. There's always that it depends model, but if you're going through and you're using the 2-point scale and you're keeping in mind that tendons, the behavior is that potentially during exercise, 30 minutes to an hour or sometime later, and then that night is typically when those tissues are going to be irritated. So you need to check in with that individual, that client, when they
Hmm.
come in next time. Don't just assume that they were okay because they didn't have any issues when they were with you, and that your load management is perfect because they didn't have any issues in session. We need to be asking as a strength coach, how did you feel that night? And if the answer is, man, I could not lay on that shoulder, it was really bothering me, then you need to look back at load management and say, I did too much. What did we change? And then make an educated guess to basically back off and then reload from there. If that,
Excellent. Excellent. Yeah. So one last question. I promise it'll
no, you're
we'll
good.
we'll
This is
we'll
good.
end it. So if I was glad that you brought up the biggest thing is don't diagnose, right? Strength coaches love to, for some reason, a lot of them that for whatever reason just want to flex their guns, or maybe they're trying to compensate for their inability or whatever the reason, but they love to show off their kinesiology and their biomechanics and try to diagnose somebody with this, that, and the other. And I think that's a slippery slope of either paranoia or false confidence. And either
Yeah.
way, they're both polarizations and they're both
Yeah.
inappropriate. And I think that a lot of times, that it's the cocky strength coach like that sees it as a sign of weakness to just keep their mouth shut. Keeping your mouth shut doesn't necessarily mean that you're ignoring them and have a deer in the headlight looks and you're scared. It's just what you said. It's just staying in the lane, being cautious and confident, and then making adjustments. Um, the other thing that I wanted to bring up, is it useful to you for since we have this information now that you've given me, would it help you if it comes to the point where the client's coming to see you, now that you've given me this information, would it help you in your process with them if I told you, like, hey, I've this has been going on for 5 days, they do have pain doing this movement, I did talk to them 6 hours in, they were, or 24 hours in, they were fine, but 6 hours in, they were hurting. Would that kind of information be helpful for you, or is that something that you're going to figure out on your own anyways?
I think that information is crucial, in my opinion. I think if you have somebody that you've been working with and they've been monitoring the load, honestly, if it's a strength coach that has not been monitoring load and they want to try and give me their answer or give me their guess, I don't care. I really don't. Like that sounds
Gotcha.
rude, but if you haven't been monitoring their load and you're not actually paying attention, you're just like, oh well, their shoulder hurts with this, and then it's like, well, what's the load been? We just throw this number up on the board and they just kind of do it themselves. If you're not monitoring it, do I want to know? Yeah, squat's hurting them, or they did this. To some degree, yes, but I would much rather know, like, hey, we backed off on some of the load. Here's what they're doing, not only from a diagnostic and understanding standpoint, but from a This patient is super strong. They're already doing all this. I don't need to give them all this basic crap anymore. Like maybe a little bit to back off and see where they're at, but maybe I diagnose, try and figure out what's going on, see what contributing factors are going on, and then I can be like, hey, Aaron, look, man, she actually was having a knee issue because she had this, whatever, right? Or it's actually, I think this is what's going on. Here's how we need to move forward as far as degrees of motion in open kinematic versus closed kinematic or whatever, depending on the particular tissue and what region it's in. So not only does it help from a diagnostic standpoint, but it helps from I know this person a little bit better. This is someone who has been doing a strength program for 3 months or for a year, or this is a beginner, and maybe have the conversation with you. But I think if it's someone who hasn't really been paying attention and all of a sudden they just say they've got shoulder pain, I'm like, and so I do want to know the details. I do want to know the lifts.
See, that was really good. That because and again, it's eye opening because I'm not in that position. And so when you're in your zone, everything's always the basics are assumed. So what I mean by that is your simple statement that I wasn't even trying to go that route with, but you just opened my eyes with, is like, you need to understand who you're dealing with, right?
Yeah.
When they're coming to you, for me, like, yeah, I see Joe Smith. He's my 400 squatter, and Jane Doe is my 150 deadlifter. Like I already have this constant continual snapshot of their levels and their ability, but when they come see you, you don't have that physical view. You don't see them in action. So I think that's a great point that you brought up, is getting a snapshot of what their abilities are, so that what I assume is when it does come time to prescription of movement and modalities, you can give the right dosage. Don't
oversimplify it, right? I mean, right. If so, let's say for Jane Doe coming in who can do A, B, C, and D, like she can deadlift, and she's deadlifting for reps, 175. She's doing great. Like she's really progressing in her program. Just think about just loading principle in general. We both know that if you back off way too much, there's atrophy, and if you go too much the other way, there's injury. And I think that's what I keep in mind is, wait a second, where is the unloading phase for this individual? Is unloading for them
Bingo.
Just going and saying, well, let's just stop, period? No, like you do that, and now it is a long road back. Now, do we make adjustments and say, hey, you're having some knee pain that's bothering you with some squats? If you change it to this type of squat, was it better? Yeah, it was fine. All right, great. I want you to back off a little bit on whatever, but let's not back up all the way to the point of we're not loading you or giving these tissues any kind of stimuli.
So as a physical therapist, it is critical to understand their level of conditioning and strength. And correct me if I'm wrong painting this picture. If you undervalue how strong the person is, and with that undervalue, you prescribe something that's such a low dose that they do start to atrophy, not only is that probably not helpful, but that can almost be counterproductive, right? Because atrophy, when we talk atrophy, we're not just talking the muscle, we're talking the ligaments and tendons as well, all the structural components that have created that.
Support potentially, yeah. And so I'll give you an example. There's a guy here in town that had, and this doesn't pertain to necessarily the tendinopathies or injuries per se, but had 2 knee replacements at the same time, and the physical therapist had him like a weekend, like doing step ups. And this guy deadlifts over 400 pounds. And they're like, yeah, let's do some step ups and some side step ups, which in most cases is just fine. Absolutely. After a knee replacement, right? It's like, yeah, that's what we would do. But if you don't understand the individual, then that individual actually, who probably needed a little bit more care, was like, this place is a freaking joke. Like they did not care to know that I want to deadlift. They didn't take my goals into consideration. They're just treating me like anybody else who's a week or 2 or 3 weeks out or whatever of having a knee replacement surgery. And I think as a physical therapist, we have to understand and we need to make sure that we're paying attention to the goals and where we're going, rather than just treating people in these silos of you had a knee replacement, you're 3 weeks out, let's do this. It depends on what kind of surgery. So surgery is a broad topic, but
Right.
I think in general, we need to understand where they're going to know how we need to load them. I don't I don't do deadlifts with every single patient that walks in with low back pain, but if they're a
Hmm.
weightlifter and they're progressing and they want to do it, absolutely, like
So
100%, because it meets their goals too.
so rehab doesn't automatically get the cop out answer of restart baseline square one, right?
No,
That's not what rehab means.
no, I think that's the thing that everyone's kind of, that's the bad rap. Are there sometimes that needs to be the case to some degree?
Sure.
Yes, there are some tissues, depending on the severity of the injury. Absolutely, it needs to be backed off to that. But I would say in discussing tendinopathies in general, I think if there aren't a ton of contributing factors, which is hard to diagnose as a strength conditioning coach, but I think when they come to me, so this guy that had the shoulder issue that I alluded to earlier, I did some things. I taught him how to basically perform the same mobilizations, some of the similar soft tissue work, and follow it up with the exercises that I would do, and then basically give him some guidelines. But he's still going and working out because he didn't want to
Sure.
lose all that.
Sure.
But on a lift like a bench press, I said, here's why it keeps being irritated. No matter what load you do, if you unload it all the way to 95 pounds or you load it all the way for him to 155 or 165, I said, it's the same because of the biomechanical issue.
Hmm.
And that's the case where I would say we may back off on that, but I don't just say let's do some ultrasound only, and that gets a bad rap and it has its place. But I'm just going to do a bunch of passive things to this really, really active individual, and I think that's where we go wrong.
Gotcha. Excellent. Awesome. Right on, man. That's what I definitely wanted to get your thoughts and evidence on. So that was awesome. Appreciate the time.
Yeah, man, no problem. I don't
Cool.
know if you're still recording or you can
No,
splice it.
yeah, yeah.
Still going.